Chronic obstructive pulmonary disease, COPD, is a common, treatable, but not curable, and largely preventable lung condition. It is characterized by persistent respiratory symptoms, such as breathlessness, cough, and sputum, and airflow obstruction, usually progressive and not fully reversible. Airflow obstruction results from chronic inflammation caused by exposure to noxious particles or gases, usually tobacco smoke, but also from environmental and occupational exposures. COPD is the preferred term for chronic bronchitis, emphysema, and chronic obstructive airways disease. Emphysema is a pathological term referring to loss of parenchymal lung texture. Chronic bronchitis is a clinical term referring to cough and sputum production for at least 3 months in each of 2 consecutive years. Exacerbations of COPD. Exacerbations are acute episodes of worsening COPD symptoms, such as increased breathlessness, cough, and sputum, which are beyond normal day-to-day variations. COPD can be classified using FEV1 or degree of breathlessness. Severity classification by FEV1, where post-bronchodilator FEV1 FEC ratio is less than 0.7. Severity of airflow obstruction is graded according to reduction in FEV1 compared to appropriate reference values based on age, sex, height, and ethnicity. Stage 1, mild, FEV1 80% of predicted value or higher. Stage 2, moderate, FEV1 50-79% of predicted value. Stage 3, severe, FEV1 30-49% of predicted value. Stage 4, very severe, FEV1 less than 30% of predicted value, or FEV1 less than 50% with respiratory failure. Severity classification by Breathlessness Medical Research Council, MRC, dyspnoea scale. Grade 1, not troubled by breathlessness except on strenuous exertion. Grade 2, short of breath when hurrying on level ground or walking up a slight incline. Grade 3, walks slower than contemporaries because of breathlessness or has to stop for breath when walking at own pace. Grade 4, stops for breath after walking about 100 meters or stops after a few minutes of walking on level ground. Grade 5, too breathless to leave the house or breathless on dressing or undressing. Causes and risk factors of COPD. Tobacco smoking. Cigarette smoking is the most common risk factor for COPD. About 90% of cases are associated with cigarette smoking. The risk of COPD, compared to non-smokers, is also increased with pipe, cigar, water pipe, and marijuana smoking. Passive smoking may also contribute to development of COPD. Occupational exposure. Occupational exposures to dusts such as coal, grains, and silica, and certain fumes or chemicals, such as welding fume, isocyanates, and polycyclic aromatic hydrocarbons, have been associated with development of COPD. About 20% of diagnosed cases of COPD are associated with occupational exposure. In lifelong non-smokers, this increases to 30%. Air pollution. Exposure to high levels of indoor air pollutants from burning wood and other biomass materials, such as coal, have been associated with increased risk of COPD. The role of outdoor pollutants in development COPD is not clear. Genetics. Less common risk factors for development of COPD include genetic abnormalities such as alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency typically presents in younger people, aged less than 45 years, and affects both smokers and non-smokers. Lung development. Factors affecting lung growth and development in utero, such as maternal smoking and preterm birth, and in childhood, such as severe respiratory tract infection and passive smoking, have been associated with reduced lung function and potentially increased risk of COPD in adulthood. Asthma. Asthma may be a risk factor for development of COPD. One longitudinal cohort study, Tucson Epidemiological Study of Airway Obstructive Disease, found that after adjusting for smoking, adults with asthma had a 12-fold higher risk of developing COPD compared to those without asthma. Complications. Reduced quality of life and increased morbidity and mortality. COPD was the 5th leading cause of disability-adjusted life years lost worldwide in 2013. Depression and anxiety. Depression and anxiety are common comorbidities in people with COPD. Cor pulmonale, right heart failure secondary to lung disease caused by pulmonary hypertension as a consequence of chronic hypoxia. Frequent chest infections, including pneumonia. Secondary polycythemia, overproduction of red blood cells as a result of hypoxia. Respiratory failure, due to increased airway resistance. Pneumothorax, due to abnormal lung parenchyma and formation of bulla. Lung cancer, COPD, may increase the risk of lung cancer. The mechanism for this is unclear, but may involve exposure to common risk factors, such as smoking, involvement of susceptibility genes, or impaired clearance of carcinogens. Muscle wasting and cachexia, due to multiple factors including effects of disease, such as breathlessness and anorexia, increased nutritional requirements and psychological factors. Muscle wasting and cachexia are associated with reduced exercise tolerance, poor health status, and increased risk of mortality in people with COPD. Prognosis. Prognosis varies from person to person, but in general, COPD is a chronic progressive condition with gradual decline in lung function and increasing symptoms over time. Factors associated with prognosis include severity of COPD on spirometry. There is a significant relationship between lower forced expiratory volume in 1 second, FEV1, and risk of exacerbation and death. Smoking cessation can reduce the rate of decline in lung function and exacerbations in COPD, in addition to decreasing mortality from smoking-related conditions such as lung cancer and cardiovascular disease. Severity and burden of symptoms, for example. Breathlessness on the Medical Research Council scale. Symptom burden on the COPD assessment test, CAT score. Exercise capacity on the 6-minute walk test. Presence of chronic hypoxia and/or cor pulmonale. Low body mass index, muscle wasting, and cachexia are associated with reduced exercise tolerance and increased morbidity and mortality. Frequency and severity of COPD exacerbations. Exacerbations accelerate rate of decline in lung function, reduce quality of life, and increase risk of mortality. Hospital admissions. Exacerbation requiring hospital treatment are associated with poorer prognosis and increased risk of death. Reported mortality rates following hospitalization for an acute exacerbation vary from 23 to 80% with a 5-year mortality rate of around 50%. Multimorbidity and frailty. Morbidity related to COPD increases with age and may be exacerbated by comorbid conditions such as cardiovascular disease and diabetes. Diagnosing COPD. History and examination. Diagnosis of COPD is based on typical clinical features supported by spirometry. Suspect COPD in people aged over 35 years with a risk factor, such as smoking, occupational or environmental exposure, and one or more of the following symptoms. Breathlessness, typically persistent, progressive over time, and worse on exertion. Chronic, recurrent cough. Regular sputum production. Frequent lower respiratory tract infections. Wheeze. Other symptoms which may be present include weight loss, anorexia, and fatigue, common in severe COPD, but other causes must be considered. Waking at night with breathlessness, ankle swelling, consider cor pulmonale, chest pain, uncommon in COPD, consider other causes. Hemoptysis, uncommon in COPD, consider other causes. Reduced exercise tolerance, take a history asking about. Onset, variability, and progression of symptoms such as breathlessness. Assess severity using the Medical Research Council and Marcida dyspnoea scale. Cough and sputum production. Ask about hemoptysis and consider other causes. Peripheral oedema. Consider cor pulmonale. Weight loss. Consider other causes. Exposure to risk factors including smoking. If the person is a current smoker, document pack years smoked. Number of cigarettes smoked per day divided by 20 multiplied by number of years smoked. Occupational or environmental exposures. Impact of symptoms on daily life and occupation. Impact of COPD on well-being in daily life can be assessed using the COPD assessment test, CAT, available in the GOLD guidelines. Previous exacerbations or hospitalization. Past medical history and comorbidities including anxiety and depression. Cardiovascular disease and metabolic syndrome. Lung or liver disease. osteoporosis, asthma. Family history including lung or liver disease. Consider underlying causes such as alpha-1 antitrypsin deficiency. Examine the person. Carry out a general examination, including vital signs such as heart rate, blood pressure, temperature, and pulse oximetry. Examine the chest and check for peripheral edema and other signs of cor pulmonale. Measure weight and height to calculate body mass index. Examination may be normal. Where present, signs may include cyanosis, raised jugular venous pressure, and or peripheral edema may indicate cor pulmonale. Cachexia, hyperinflation of the chest, use of accessory muscles and or pursed lip breathing, wheeze and or crackles on auscultation of the chest. Spirometry is required for confirmation of diagnosis. A postbronchodilator FEV1 FEC less than 0.7 confirms persistent airflow obstruction. Consider other causes in older people without typical symptoms of COPD who have an FEV1 FEC ratio less than 0.7. Consider COPD in younger people who have symptoms of COPD even when their FEV1 FEC ratio is above 0.7. Consider alternative diagnoses and be aware that COPD can coexist with other conditions. Investigations. Arrange investigations including chest X-ray to help exclude other causes such as lung cancer, bronchiectasis, tuberculosis, and heart failure. Full blood count to identify anemia or polycythemia. Spirometry. Measure post-bronchodilator spirometry to confirm the diagnosis of COPD. Do not routinely perform reversibility testing as part of diagnostic workup. Depending on the clinical situation, additional investigations may be indicated such as sputum culture, if sputum is purulent and persistent, to identify organisms. Serial home peak flow measurements to exclude asthma if diagnosis is in doubt. ECG and serum natriuretic peptides. If cardiac disease or pulmonary hypertension are suspected, echocardiogram may also be indicated. CT thorax. If symptoms seem disproportionate to spirometry measurements, another diagnosis, such as fibrosis or bronchiectasis, is suspected, or an abnormality on chest X-ray requires further investigation. Serum alpha-1 antitrypsin. Consider alpha-1 antitrypsin deficiency in people with early onset of symptoms, minimal smoking history, or a positive family history. Referral to a specialist for management and screening of family members is required if alpha-1 antitrypsin deficiency is identified. Spirometry, post-bronchodilator spirometry, should be performed and interpreted by an appropriately trained health professional to confirm the diagnosis of chronic obstructive pulmonary disease, COPD. Spirometry should be carried out 15 to 20 minutes after the person has inhaled a short-acting bronchodilator, for example, 400 micrograms salbutamol delivered via a spacer device. Local protocols may vary. Airflow obstruction is defined as a post-bronchodilator ratio of forced expiratory volume in 1 second, FEV1, to forced vital capacity, FEC, of less than 0.7. Other causes should be considered in older people who have a FEV1 FEC ratio below 0.7, but do not have typical symptoms of COPD. COPD should be considered in younger people with typical symptoms, even if FEV1 FEC ratio is above 0.7. Differentials. The differential diagnosis of chronic obstructive pulmonary disease, COPD, includes asthma. COPD and asthma can be difficult to distinguish clinically and may coexist. Consider asthma if the person has a family history, other atopic disease, or nocturnal or variable symptoms, is a non-smoker, or experienced onset of symptoms at younger than 35 years of age. Bronchiectasis. Clinical features include copious sputum, frequent chest infections, a history of childhood pneumonia, and coarse lung crepitations. Heart failure. Clinical features include breathlessness when lying flat, a history of ischemic heart disease, and fine lung crepitations. Lung cancer. Consider if the person has a persistent cough, hemoptysis, weight loss, or persistent hoarse voice. Interstitial lung disease, such as asbestosis, pneumoconiosis, fibrosing alveolitis, or sarcoidosis. Clinical features include a dry cough and fine lung crepitations. Anemia. Clinical features include fatigue, breathlessness, and palpitations. Tuberculosis, TB. Clinical features include persistent productive cough, which may be associated with breathlessness and hemoptysis. May coexist with COPD, cystic fibrosis, upper airway obstruction, for example, tracheal tumor. Stable COPD management. At each clinical review, at least annually, ensure that there is understanding about COPD, exacerbation triggers, and the importance of smoking cessation. Patients should be offered a pneumococcal and annual influenza vaccination. Ensure that the patient is taught the correct inhaler and, if appropriate, spacer technique and observe their technique prior to prescribing inhalers. The choice of device is based on a number of factors, including the patient's preference and their ability to use it correctly. Spacers should be cleaned using warm water and washing up liquid not more than once a month. The spacer should air dry. Pulmonary rehabilitation, offer if MRC breathlessness grade 3 and above, and the patient is able to walk and does not have unstable angina or recent myocardial infarction. Initial pharmacological therapy. SABAs, or short-acting muscarinic antagonists, SAMAs, for acute breathlessness. For example, salbutamol 100 micrograms, 1 to 2 puffs, as needed. If still breathless or exacerbations, then there are no features suggesting steroid responsiveness. Combination long-acting muscarinic antagonists, SAMAs and LABAs, for example, Spialto, Respimat, or Ultibro Breechhaler. If still breathless or having exacerbations, and there are features suggestive of steroid responsiveness. Combination LABA and ICS, for example, Symbicort Turbohaler. Features suggestive of steroid responsiveness. Previous secure diagnosis of asthma or atopy. High blood eosinophil count greater than 0.3. FEV, one variation over time greater than or equal to 400 ml. Diurnal peak flow variability greater than or equal to 20%. Dysmyq, P, peculation, worsening symptoms, or if they have had a severe exacerbation requiring hospitalization or 2 moderate exacerbations requiring prednisolone antibiotics in a year. Combination LAMA and LABA and ICS, e.g. Trelegy ellipta. If treatment escalation was due to worsening symptoms and the patient was previously not using an ICS, review this therapy after a 3-month trial. Additional therapies. Oral modified release theophylline for persistent breathlessness despite inhaled therapy, or if the patient is unable to use inhaled therapy. Plasma levels must be monitored, and clinicians should be aware that there are many potential drug interactions. Mucolytic therapy, carbamazepine, for patients with a chronic productive cough. Long-term oral corticosteroid therapy is not recommended, but some patients with advanced COPD are unable to wean from oral steroid following an exacerbation. Physiotherapy if excessive sputum production. Dietetic advice plus nutritional support for abnormal BMI. Management of anxiety and depression. Further treatment escalation with specialist COPD team guidance. Oxygen, long-term oxygen therapy, LTOT. Home nebulizers for disabling breathlessness despite maximal inhaled therapy. Prophylactic antibiotics if frequent, prolonged, or severe exacerbations. For example, azithromycin 250 milligrams 3 times a week. Prior to starting azithromycin, the patient must have an ECG to check QT interval, baseline LFT, and sputum. Culture to identify resistant organisms and atypical mycobacteria. They must be warned about the small risk of hearing loss and tinnitus with this therapy. Azithromycin does not need to be stopped during an acute exacerbation. Lung volume reduction procedures and transplantation. End-stage COPD with unresponsive breathlessness may require palliative opioids and sedatives. Ambulatory oxygen therapy AOT can be delivered via small, lightweight cylinders or portable liquid oxygen systems along with oxygen-conserving devices. AOT is suitable for motivated patients with resting hypoxemia, who on formal assessment are shown to have exercise desaturation and an improvement in exercise capacity with oxygen. It can also be given to patients on LTOT who wish to continue oxygen therapy outside their home. Criteria for referral to specialist COPD team. Diagnostic uncertainty. Alpha-1 antitrypsin deficiency is suspected. Severe COPD, sudden worsening of condition, or difficulty managing symptoms. Frequent infections, exacerbations. The patient requires assessment for oxygen, home nebulizers, or continuous oral steroid therapy onset of cor pulmonale. Assessment for lung volume reduction procedures and transplantation. Criteria for assessment for long-term oxygen therapy patients should have stable COPD on optimal medical therapy. With one of the following: very severe COPD, FEV, 1 less than 30%, cyanosis, polycythemia, peripheral oedema, a raised JVP oxygen saturations of 92% on room air. Assessment process for long-term oxygen therapy. Assessment comprises 2 ABGs at least 3 weeks apart. LTOT may be supplied via a concentrator if PaO2 is less than or equal to 7.3 PaO2, 7.3 day kPa, along with one of secondary polycythemia, peripheral oedema, or pulmonary hypertension. LTOT should be used for greater than or equal to 15 hours a day. LTOT should not be offered to patients who continue to smoke after referral to specialist stop smoking services. Acute exacerbation of COPD management. An exacerbation of COPD is when there is an acute worsening of symptoms beyond normal day-to-day variations. Mild, increased need of existing medication which the patient can manage in their own environment. Moderate, requires prednisolone and/or antibiotics. Severe, requires hospitalization. Primary care patients should be referred for urgent secondary care if oxygen saturations are less than 90% or if they are already on LTOT, have significant comorbidities or frailty, are unable to cope at home, or it would be clinically inappropriate to treat them in the community, e.g., severe breathlessness, impaired consciousness, etc. Secondary care bedside investigation, sputum at cans if sputum is purulent, ECG, bloods, ABG, to assess for respiratory failure, record-inspired oxygen concentration FPC, WAMP, CRP, theophylline levels if taking orally, blood cultures if pyrexic, imaging, chest X-ray. Pharmacological management. Nebulized bronchodilators, for example, salbutamol 2.5 milligrams QDs plus PRN. Ipratropium bromide 500 micrograms QDs. Nebulizers should be driven by room air with supplemental oxygen delivered by nasal cannula if needed. Corticosteroids. In an emergency or if the patient is unable to swallow, an IV preparation may be given, for example, hydrocortisone 100 milligrams QDs. If able to have orally, prednisolone 30 milligrams should be prescribed for 5 days. Oxygen therapy targeted to achieve pulse oximetry saturation 88 to 92% for hypercapnic patients and greater than 94% for other patients. Antibiotics if bacterial infection is suspected. A broad-spectrum agent should be used initially, guided by local protocol and reviewed following sputum or blood culture results. Oral regimens are typically given for 5 days. IV antibiotics are reserved for patients who are unable to take oral antibiotics or are severely unwell. Examples of broad-spectrum oral regimens: amoxicillin 500 milligrams TDs, coamoxiclav 500, 125 milligrams TDs, doxycycline, 200 milligrams initially and then 100 milligrams OD, and clarithromycin 500 milligrams twice a day. Diethiophylline can be used if steroids and inhaled bronchodilators do not lead to clinical improvement. Check theophylline level within 24 hours of starting. Non-invasive ventilation, indicated if the patient has hypercapnic, type 2, ventilatory failure with acidosis, PS less than 735. Despite maximal medical treatment, patients on NIV require high-level monitoring, including regular arterial or capillary blood gas measurement. NIV should be delivered in a dedicated setting with appropriately trained staff. All patients started on NIV should have a clearly documented escalation plan, including agreed ceilings of therapy. Functional status and comorbidities are important determinants of suitability for intubation and ventilation on the intensive care unit. In addition to age and FEV1,